She is a very senior gynecologist and one of the pioneer of the Nagpur city to establish the test tube baby center. So, Madam is always having the excellent academic record. Was a gold medalist, and we know her personally as well. And she is always so helpful and always guiding to the junior from upfront. Thank you so much, madam. And you are now invited to speak on thin endometrium challenges and diagnosis and.
Good afternoon, chairpersons and dear audience. At the outset, I would like to express my thanks to Team ISAR Bhopal, Dr. Monica and Randhir for having given me the invite. What I'm going to talk about in the next 15 minutes is thin endometrium. What are the challenges in diagnosis and management? And I'm so happy that I'm talking on thin endometrium on not a very thin audience, a reasonably well audience on the concluding day of the conference. So when we talk of endometrium, we need to know successful implantation. We need an embryo at the blastocyst stage. We need a receptive endometrium. We need an embryonic endometrial cross communication. And we all know this is a very highly regulated and complex mechanism. Now, there have been advances in assisted reproductive technology cycles, but still the implantation rate is 25 to 35%, as endometrial receptivity still remains both puzzling and challenging. Determinants of successful implantation and endometrial receptivity, we are still doing research into that. Advent of bioinformatics by non-invasive analysis of endometrial secretions even in transfer cycle is the way forward, and we all need to know about the window of implantation. Now when we talk of window of implantation, this is a very transient and unique movement. Day 19 or 20 of the natural menstrual cycle, day 4 or 5 after the progesterone production or administration. This window expands for 4 to 5 days corresponding to day 19 to 24 of the menstrual cycle, and implantation occurs on day 7 to 10 after the LH surge. So, what do you decide? What is a receptive endometrium, and how do you diagnose that your endometrium is receptive or not? You have high resolution ultrasonography to monitor your follicular development and endometrial responsiveness, where you concentrate on endometrial thickness, the endometrial pattern, the blood flow impedance, the uterine volume, and so the optimum endometrium thickness, whether it is 6, 7, 8, or 9 or 10. The recent meta-analysis of 10,724 cases have reported a cutoff of 7 millimeter. Now, what are the causes of thin endometrium? Inflammatory, iatrogenic, idiopathic, hyperandrogenic state, older women, 5% of older women less than 40 and 25% of women more than 40. And this is probably due to decreased endometrial vascularity. And we all know controlled ovarian hyperstimulation affects the endometrial receptivity in a different way by making the endometrium not receptive to implantation. So we need to know now, amongst the inflammatory causes, I need not elaborate here: infections, acute and chronic pelvic inflammatory disease, and in India, tuberculosis. Iatrogenic. This is something very, very important. We all need to know who are practicing infertility and IVF, especially previous trauma of the uterus like cesarean, repeated vigorous curettage, removal of an intracavitary polyp or myomas which has not been done meticulously. Drugs like clomiphene, consistent use of clomiphene cycle after cycle is going to reduce the endometrial thickness, controlled ovarian hyperstimulation and ovulation inductions, and of course, antitumoral therapies like radical surgeries, chemotherapies, and radiotherapy. Also, hyperandrogenic state. Lot has been talked about polycystic ovarian syndrome in the past session. Endometrium in polycystic ovary syndrome patients has an inverse relation with the serum and the total testosterone, and a positive correlation with the body mass index. Controlled ovarian stimulation, we have talked about the adverse effects on the endometrial receptivity. Now, we need to know as to why thin endometrium affects implantation at all. Now, in thin endometrium, there is poor growth of the glandular epithelium. There is decreased VEGF expression. There is poor vascular development. And the hypothesis now, which has come off, which says that when you're transferring the embryo on the thin endometrium, it is close to the basal layer, and this basal layer is rich in reactive oxygen species, and so the implantation is affected. And the second hypothesis is in a thin endometrium, there is malfunction of the endometrial stem cells and the progenitor cells. So then how do you measure the endometrial thickness? This is just to run through the slide. We all know how to measure the thickness, ideally by transvaginal ultrasound, maximum distance between the ecogenic interfaces of the myometrium and the endometrium in the sagittal plane of the uterus. And you have the color flow Doppler ultrasound. You have the three-dimensional imaging of the endometrium, and all these modalities to tell you now, these are non-invasive modalities. Gone are the days of endometrial biopsy to tell you whether your endometrium or not. Now, coming to the treatment options, there are various treatment options to improve the endometrial thickness in women with thin endometrium. The most glorified is the extended use of exogenous estrogens, aspirin, vaginal sildenafil citrate, tocopherol, pentoxifylline, L-arginine, granulocyte colony stimulating factor, and the platelet rich plasma. Let us look at them quickly one by one. So, exogenous estrogens, the estrogens administered for 10 to 12 days is the standard regimen. In extended use, administration is done for a higher dose and for a longer period. Vaginal administration of micronized estradiol also significantly increases the serum E2 level and, most importantly, the endometrial estradiol concentration. We have the estradiol gel application, and a study by Chen et al. Proved that when estrogen therapy was started on day 3 of the cycle and the administration was continued for a long duration, a sensible increase in the endometrial thickness was observed. And mean endometrial thickness increased from 6.7 to 8.6 with a pregnancy rate of 38 versus 4.3%. Fortune et al. Also showed that vaginal estradiol administration improved endometrial thickness. Aspirin, all of us are using aspirin left and right. Low dose aspirin is an irreversible inhibitor of cyclooxygenase. Daily dose of low dose aspirin promotes a shift from the thromboxane A2 to prostacycline, and it inhibits platelet aggregation, leads to vasodilatation, and increases the blood perfusion. Low dose aspirin may improve implantation by enhancing uterine blood flow and endometrial receptivity. A meta-analysis by Gelbaya et al. Included 6 studies and over 2,500 patients and found no difference between women who received low dose aspirin versus placebo. Roop et al. In 2008 analyzed 10 studies with 2,800 patients in meta-analysis comparing low-dose aspirin versus placebo in women undergoing IVF, and reported a slight improvement in the clinical pregnancy rate. Updated meta-analysis does show 12 studies with 4,373 patients with a slight but not significant benefit for low dose aspirin over placebo. So, to conclude, benefit of low dose aspirin may be minimal at its best. Then we come to sildenafil. It's a nitric oxide which relaxes the vascular smooth muscle through the CGMP pathway. Sildenafil citrate prevents the CGMP degradation and thus causes vasodilation. There has been a pilot study by Sher and Fish in which 105 women with prior unsuccessful IVF associated with thin endometrium were taken up in the study, in which oral contraceptive pills, long down regulation, and FSH stimulation protocol, sildenafil suppository was given in a pretty high dose. And what they found is when they divided the patients in 2 groups, they found that the other potential causes of IVF failure were not addressed in this paper. There were no randomized controlled trials. Remember this very well. To date, there are no randomized controlled trials in the use of sildenafil. And the another possible hypothesis is sildenafil does lead to reduction in the incidence of the natural killer cells in the endometrium of women with recurrent miscarriage as a result of sildenafil therapy. Now, this is an observational study. Then you come to other adjuvants like pentoxifylline, tocopherol, LRG9. When your patient has a thin endometrium, you're struggling to give all these adjuvants, but mind well, there are no reported trials or case control studies with the use of adjuvants. Now coming to granulocyte colony stimulating factor, this was a pilot cohort study of GCSF in unresponsive thin endometrium, a pilot study by Norbert Glacier way back in 2012, and this sort of found a new therapeutic approach to improve the endometrial thickness. GCSF is a cytokine that stimulates neutrophilic granulocyte proliferation. Human decidua is now thought to control the trophoblast invasion via secretion of cytokines, and there does occur cellular proliferation and growth at the endometrial tissue. So 21 patients on the day of HCG, endometrial thickness less than 7 millimeter, cycle cancellation. So embryo transfer off-label use of GCSF was done for the very first time. 300 microgram per ml of filgrastim was infused by Tomcat catheter by 1 ml insulin syringe, and 48 hours later, they infused GCSF if the thickness was less than 7 millimeter. So then there are various studies which tell us as to what is the impact of GCSF stimulating factor. Now, there was a paper which said you should give subcutaneous injection as well as you should do an intrauterine perfusion of GCSF to improve endometrial receptivity. Then there was a revolution. Platelet rich plasma came with a bang, and it still is there. And this platelet rich plasma stimulates the cellular processes which are involved in endometrial regeneration. Chang et al. Reported for the first time with improvement in the endometrial thickness after intrauterine instillation of autologous PRP. Platelet rich plasma is also introduced into the uterine cavity with Tomcat catheter for 0.5 to 1 ml. Repeat PRP infusion is done 48 before embryo transfer if there is no successful improvement. Endometrial thickness after PRP installation can be reassessed 48 to 70 hours after the installation. There are a lot of papers which say that this could be a potential new strategy in the endometrium treatment productive technology. Now, to come over to stem cell therapy, lot has been talked about in this forum about the stem cell therapy, but because of the ethical issues and guidelines, much advocated and rampant in our country like India. Now, what does stem cell therapy do? Endometrial reconstruction has been recently suggested as a promising option for achieving pregnancy in the uterus of women with severe endometrial damage, like those with Asherman syndrome or atrophic endometrium. So, cell based therapy, this is the new concept in endometrial syndrome. Where nothing works, the cell based therapy has a promise. And this is something which lot has been talked about Kaberi, in her artificial intelligence, this and that. So now, we are looking onto a non structured scaffold. We are moving into the era of tissue engineering, where we have biomaterial science, we have three-dimensional scaffolds, transplantation of the bone marrow mesenchymal cells, loaded collagen, with hyaluronic acid. Hydrogels are presumably suitable candidates for endometrial regeneration in the future, and it has been suggested that HA receptors exist throughout each estrous cycle, and they have a high concentration of PEGF, IGF-1. High concentration of these are seen in the bone marrow mesenchymal cells. So, to conclude, infertility is a global disease, affects a great number of females, both a social and medical issue. Endometrium plays a vital role in maternal health and reproduction. Maintaining its physiological structure, eliminating its defects, and restoring it after injuries are of paramount importance today. And advent of new cell therapy should change the dynamics of the endometrium and give the joy of motherhood to more and more infertile couples who come on our doorstep daily. So, in the end, I would like to conclude: be a deliverer of blessings, be a creator of miracle, and be a vehicle of grace. And gratitude is the world's most beautiful language and the most genuine way for people to act. And I thank you for a patient hearing.
A very well summarized topic. Very difficult case scenario when it comes to treatment. A lot of experiments are definitely going on. My question is, what is your experience with PRP? No, like sonographically under sonographic guidance or hysteroscopy?
Yeah, see, I'm not putting it trans uterine purpose of platelet rich plasma. And when I'm doing my IVF cycles, mostly which are frozen embryo transfer cycles, we usually assess it on day 10 of an FET cycle, assess the endometrium, the Doppler, the other parameters, the endometrial ecogenicity and the texture, and we do instill platelet plasma in these patients on day 10, call them again for sonography on day 12, and then plan the cycle.
Wanted to know if whether you are doing it sonographically.
No,
No,
yeah, under ultrasound guidance, I'm doing this
like
procedure in
not
the OT.
injecting it directly into the endometrium.
Yeah, I'm doing it as an in the operation.
So which needle you are?
No, I'm not putting it transcendentally.
I
I'm
wanted
using
to
the
know,
kinetic
no, that
cannula.
I know.
Yeah,
I wanted to know your take whether you are doing installation in the endometrium,
so
directly injecting.
yeah, just like
No, no, that is not injection. That is infusion.
yeah. So I'm doing an.
I'm
I
talking
told you
about
I'm
injection.
not doing a
Yeah, okay.
transhysteroscopy. Not
Yeah, many people nowadays
before
are
the embryo transfer. I don't
over
want to
pick up data.
damage the.
But the problem is PRP is very less.
Yeah. And mind well, before doing the procedure of embryo transfer, I in no way want to damage the inject subendometrial
Usually they say
PRP.
on day 7 of the same cycle, prior cycle or in the